Hello, everyone. I'm Dr. Chandana. I'm consultant pediatric hematology oncology, BMT at KIMS, Cuddles KIMS Hospital. So today we're going to discuss about approach to autoimmune hemolytic anemia. Autoimmune hemolytic anemia is a kind of hemolytic anemia in which autoantibodies are triggered, and then they target the self hemoglobin, and then there is a sudden drop in the hemoglobin level, due to which there are life-threatening conditions. Life-threatening conditions. So here we can see that how is it defined as? It's defined as a collection of disorders characterized by the presence of autoantibodies that bind to the patient's own erythrocytes, are leading to the premature red cell destruction, that is called hemolysis. So whenever the rate of hemolysis exceeds the ability of the bone marrow to produce the destroyed red cells, that time when the child clinically presents with hemolytic anemia, that is when we say it is autoimmune hemolytic anemia. So there are all number of signs and symptoms that we look for to look at the autoimmune hemolytic anemia. Here we can see the classification. So autoimmune hemolytic anemia primarily divided into warm reactive AIHA, cold agglutinin disease, and paroxysmal cold hemoglobinuria. So coming to the autoantibody isotype, in the warm reactive AIHA and paroxysmal cold hemoglobinuria, both of them are IgG subtype, and in cold agglutinin disease, it is IgM. In the thermal, when it comes to thermal reactivity, like the name suggests, the warm reactive AIHA, it's more reactive at warm temperatures, and coming to paroxysmal cold hemoglobinuria and cold agglutinin disease, it is more reactive at the cold temperatures. The ability to fix complement, that is C3, is more in paroxysmal cold hemoglobinuria and cold agglutinin disease, and it is variable in the warm reactive AIHA. So the DAT KIMS is not typically performed in the warm reactive AIHA, and at 37 degrees centigrade, it's positive for IgG plus or minus a complement C3. Coming to the paroxysmal cold hemoglobinuria, it's positive for IgG and C3 at 4 degrees centigrade, and it's negative for IgG, positive for C3 at 37 degrees centigrade. In the cold agglutinin disease, at 37 degrees centigrade, it's negative for IgG and positive for C3. And in 4 degrees centigrade, it's negative for IgG and positive for C3. So this is how we interpret the DAT KIMS test based on the temperature specificity. Coming to the antigen reactivity, in the warm reactive AIHA, the RH is the most commonly predominant. Coming to PCH and cold agglutinin disease, in PCH it is capital P, and in cold agglutinin disease it is capital I or small I. Coming to the site of hemolysis, in the site of hemolysis, spleen is the most common site for hemolysis in warm reactive AIHA, and in paroxysmal cold hemoglobinuria, it is intravascular, and cold agglutinin disease, it is liver or intravascular. The first line therapies is glucocorticoids in warm reactive AIHA. In paroxysmal cold hemoglobinuria, it is avoidance of cold. In cold agglutinin disease, it is avoidance of cold. Secondary therapy is splenectomy, rituximab in warm. PCH, it is glucocorticoids. In cold agglutinin disease, it is rituximab. So warm reactive, all of these AIHAs, different ones, are all divided again into primary and secondary. I'm going to discuss about how we approach the primary AIHA in the coming slides. But the most common causes for warm reactive and secondary causes are autoimmune or inflammatory disorders, Evans syndrome, PID, AID, malignancy, infection, and post-transplant. Coming to the cold agglutinin disease, the secondary infections are mycoplasma, EBV. Malignancies are lymphomas. In the PCH, it's mostly post-infectious that we see. So here, I'm just going to simply divide primary AIHA and secondary AIHA. In primary AIHA, the RBC antibodies are present that cause hemolytic anemia, but there is no evidence of systemic infection. Coming to secondary AIHA, there is an underlying systemic infection that triggers the secondary AIHA. And primary AIHA accounts for 40 to 50% of pediatric AIHA cases. And warm reactive antibodies, except post-infectious, typically cause cold agglutins. So primary AIHA is mostly warm antibodies, and secondary AIHA, because there's a number of secondary causes, SLE, AIHA, autoimmune inflammatory disorders are most common. Then in autoimmune disease, SLE, Sjogren's disease, scleroderma, JIA, dermatomyositis, vitiligo, ulcerative colitis, autoimmune hepatitis, type 1 diabetes mellitus, autoimmune thyroiditis, autoimmune lymphoproliferative syndrome. All of these are part of the autoimmune diseases that may lead to autoimmune hemolytic anemia. Children with these disorders probably have a genetic susceptibility to immune dysregulation. Evaluating for immune dysregulation happens once you rule out the main possible causes, and then we go into finding if there is a genetic susceptibility to immune dysregulation, which leads to expansion and proliferation of autoreactive B lymphocytes. Family history of autoimmune disorders. Sometimes SLE has a weak positive DAT without any clinical or lab evidence of hemolysis. At that time, we don't consider this entity as autoimmune hemolytic anemia. We simply wait and treat the underlying cause, and not really intervene for autoimmune hemolytic anemia. So these are I just summarized what we should even look for when you have autoimmune hemolytic anemia, which is going on for a long time. That is immunodeficiency, event syndrome, malignancy, infection, transplantation, and drugs. Epidemiology, it is most annual incidence is about 0.8 to 1.25 cases per 1 lakh children. It's more common than acquired aplastic anemia, but less common than ITP. It can affect any race, any ethnicity, and can present at any age. Adolescents and young children less than 2 years of old who present with AIHA are more likely to have an underlying systemic illness, that is secondary AIHA, and a more chronic course. Clinical presentation, it's very non-specific. Symptom determined by severity of hemolysis. If the hemolysis is quite severe, that is when the symptoms are quite predominant. And also the clinical presentation may range from asymptomatic to severe and life-threatening. Presenting symptoms are weakness, fatigue, shortness of breath, dizziness, and pallor, jaundice, icterus, and painless dark urine. Other non-specific symptoms are abdominal pain or fever. Warm AIHA is pallor, jaundice, and fever. So a well-compensated to profound anemia and severe life-threatening presentation. So this is all a plethora of clinical presentation which I've just summarized, which we normally come across in a daily practice. But once you suspect AIHA, these become quite predominant and you need to evaluate further. In cold agglutinin disease, so acrocyanosis is quite seen with purple to gray discoloration of the skin on the most acral parts, at fingertips, toes, nose, and ears. These changes disappear upon warming. Passage of painless dark urine in colors ranging from gold to red to black usually signifies hemoglobinuria, secondary to intravascular hemolysis, and suggestive of cold reactive AIHA, such as cold agglutinin disease or paroxysmal cold hemoglobinuria. Patients with warm AIHA do not typically have hemoglobinuria unless there is a component of complement fixation. So this is a diagram which shows in the first diagram A, it shows a spirocyte in a patient with warm AIHA, and in the second one it shows how there's clumping of the red cell. Red cells are red cell agglutination in cold agglutinin disease. This is how it looks under the microscope. Coming to the patient history, how do you first take the history for autoimmune hemolytic anemia? We should first ask if there are any previous similar episodes, any benign previous medical history, history of autoimmune disease or PID in first degree relatives, any recent acute infectious illnesses, signs and symptoms of underlying systemic illnesses, and concurrent medications. In physical findings, the child looks pale and jaundice, especially apparent in conjunctiva and palms. Tachycardia, systolic flow murmur reflecting high output anemic state. Cardiovascular compromise is uncommon unless the hemoglobin is less than 5 gram per deciliter, and organomegaly is present or absent, but based on clinical conditions. Lab investigation, CBC with RBC indices and platelet count, RBC indices, reticulocyte count, peripheral blood smear, direct antiglobulin test, cold agglutinin titer, urine analysis and kidney function tests, serum markers of hemolysis like bilirubin, LDH, AST, ALT, haptoglobin, and plasma-free hemoglobin. So this is a picture which shows the DAT positive and DAT negative hemolytic anemia and its causes. So in coming to DAT positive, it is autoimmune hemolytic anemia, alloimmune hemolytic anemia, or drug-induced hemolytic anemia. And in DAT negative, there are something called as hemoglobinopathies, which is in which there is sickle cell disease, infections like malaria, Clostridium, enzymopathies, G6PD deficiency, membranopathies, hereditary spherocytosis, and thrombotic microangiopathies, thrombotic thrombocytopenic purpura. Further evaluation, first step is, so this is how we evaluate for autoimmune hemolytic anemia. Step 1, it is a normocytic macrocytic anemia with a raised reticulocyte count, raised unconjugated bilirubin, reduced haptoglobin, and blood smear with polychromasia or more specific features such as spirocytes or agglutination, which the pictures which I've shown previously. So when you do a full blood count, this is what you look for. We should look for the raised reticulocyte count, raised unconjugated bilirubin, reduced haptoglobin, and blood smear with polychromasia with a normocytic or macrocytic anemia. But having said that, none of these tests are specific or sensitive for hemolysis because raised LDH can happen even in the liver disease and reduced haptoglobin can also happen in the liver disease. Reticulocytopenia can occur in AIHA secondary to bone marrow infiltration by lymphoproliferative disease or parvovirus infection. Intravascular hemolysis, raise in LDH, red cell fragments on smear, or the presence of urinary hemosiderin. All of this causes intravascular hemolysis. Step 2, once the hemolysis is confirmed, further investigation is needed if hemolysis is immune, that is by DAT. Standard direct antiglobulin test demonstrate IgG and or complement, usually C3d, is bound to red cell membrane. Autoantibodies can be both IgM and IgA classes and extended DAT. So these are the main things. Once hemolysis is confirmed, we look at the direct antiglobulin test. So direct antiglobulin demonstrate IgG, complement to usually C3d, and autoantibodies can be IgM and IgA extended DAT. This is a table which summarizes all of these tests, what I've just discussed in a nutshell. So the first primary evaluation shows, causes a hemolytic screen. Like I discussed, FBC, blood smear, LDH, haptoglobulin, reticulocyte count, urine for hemosiderin, urine dipstick for microscopy. Then the detection of underlying disorders, that is serum immunoglobulins, electrophoresis with immunofixation, HIV, HBV, HCV, anti-dsDNA, ANA, CT chest, abdomen, and pelvis. Coming to the additional investigations in selected patients with AIHA, bone marrow examination. That is in the bone marrow examination, we look at the CAD, age more than or equal to 60 years, features in history, examination, FBC or smear suggesting possible marrow infiltration. We look at all the UCNEs, LFTs, clotting, BPA, urine dipstick if you're suspecting of thrombocytopenia to exclude DIC or pregnancy-associated TMAs. In infection screening, you look at the travel history, you look at the age and the symptoms. And you'll also look at the peripheral T cell subsets creatinine LFT clotting in those children which you suspect Evans syndrome, parvovirus and hematinics if there is reticulocytopenia. These are the additional serological tests in selected patients with AIHA. So you look at the direct agglutinin test, cold antibody titers, monospecific DAT for IgM, G, A, C3d, red cell elute, Donathan Landsteiner, that is for PCH, thermal range for cold antibodies, that is if it is less than 1:64 and more than 1:64. Less than 1:64, so we have to evaluate for a few other causes, and more than 1:64, it's called cold agglutinin disease, and we need to rule out infections, autoimmune conditions, and there are some things called, even in lymphoma, you can have cold agglutinin disease. So step 3, so the first step I've discussed, second step was to do a DAT, and based on DAT, elucidate the cause. And step 3, so after identifying the hemolytic anemia and doing the DAT, we look at the obvious causes. So the obvious causes first we should think of is a delayed transfusion reaction from a recent transfusion. Sometimes if there is a minor mismatch or some antibodies against, there could be a delayed transfusion reaction. Then there is alloimmune hemolysis following solid organ or allogenic stem cell transplantation, drug-induced immune hemolysis or a hemolytic disease of the newborn will be quickly identified by clinical assessment. So when considering alternatives, it should be remembered that a positive DAT can occur in a passive deposition of antibodies or immune complexes in liver disease, chronic infections, like SLE, malignancies, renal disorders, and following drug therapy in such as IVIG or thymocyte globulin. With IVIG, sometimes there is a deposition of the IgG antibodies which last for 21 days, and once these antibody titers come down, that is when the autoimmune hemolytic anemia also comes down. This is all passive because of passive deposition of the antibodies. If there is no alternative causes identified, then a diagnosis of AIHA can be made. A diagnosis of DAT negative AIHA can be made following careful exclusion of alternative causes of hemolysis and confirmation by a sensitive technique where available and is supported by a response to steroid therapy. So this is a diagram which shows how you approach AIHA in a simple format. So first, you have an evidence of hemolytic anemia, like I discussed. You look at the full blood count, you look at the peripheral smear, you look at polychromasia, cystocytes. Are there any normocytic, microcytic anemia, reticulocyte count increase, decrease in haptoglobulin, increase in LDH? All of these are evidence of hemolytic anemia. Then you go ahead and do a direct antiglobulin test. You look for if it is a direct DAT positive or negative. DAT positive, you have few causes. DAT negative, you have few causes. You have to elucidate which ones are which one. Then you do a clinical assessment. Once you do a clinical assessment, you should rule out alternative causes for hemolytic anemia and a positive DAT. So you look if there is a post-transplant ABO mismatch, post-IVIG, any unrelated cause of hemolytic anemia with an incidental positive DAT. So these are something which first we rule out. Then, so HTR is hemolytic transfusion reactions. And then, so this is when you do the clinical assessment. So if you have evidence of hemolytic anemia, you should also consider alternative cause of hemolytic anemia. If cause is still unclear, repeat DAT by column agglutination method. And then you should look for the monospecific DAT. That monospecific DAT is you get the titers for IgG, M, A, C3D. If this was not done previously, and then when you get your IgG, your C3, MA, you get to know more because warm antibodies have more of IgG. C3D complement fixation is also plus minus in warm. Then all of this, so you can, based on these monospecific DAT, you can divide PCH, cold agglutinin disease, and autoimmune hemolytic anemia. Then we look at the Donathan-Landsteiner in children with hemoglobinuria. When you look at the urine for hemoglobin and urine hemosiderin, when you have these deposits, you should retrospectively look for Donathan-Landsteiner antibody to rule out PCH. That is paroxysmal cold hemoglobinuria. And when you look at the alternative cause and all of them are negative, then you have an antibody found by sensitive test, and then that is steroid responsive hemolytic anemia. So that is called a DAT negative AIHA. If there is no, then you have to reassess your causes for hemolytic anemia. So now you've seen the alternative causes, and then you found no alternative cause for hemolytic anemia, and still there is a positive DAT. Then it is called autoimmune hemolytic anemia. And that time you look at IG. So when you do a monospecific DAT, if it's only IgG, then it is a warm AIHA. And if it is C3 complement fixated plus minus IgG, then you do a direct anti-agglutination test screen for at RT, and then you look for the antibody titers. So when you look at the antibody titers, if it is less than 164, it's insignificant for cold agglutinin disease. If it is more than 1:64, then it is cold agglutinin disease. At that time, again, you have to look for if there is a complement fixation or there is a complement fixation with IgG. So once you have that information, you have to then further clinically and serologically assess for other causes for autoimmune hemolytic anemia, any underlying causes, any systemic, any serological assessment of antibodies you can see, and then you can name them as either mixed AIHA or cold agglutinin disease. Then when you do a agglutination test, and if it is negative, so age, if it is less than 18 years, hemoglobinuria, cold-associated hemolysis, atypical serological features, all of these are present. Then, if yes, then Donat-Landsteiner. If it is positive, it is paroxysmal cold hemoglobinuria. If negative, it is warm AIHA. How do you treat AIHA? So the optimal treatment of AIHA depends initially upon the severity and chronicity of anemia, degree of signs and symptoms, characteristics of the autoantibodies, and nature of the underlying disease if present. So these are the four things you should keep it in mind. You should assess for your own when you're treating autoimmune hemolytic anemia. Severity and chronicity, degree of signs and symptoms, characteristics of the autoantibodies, and nature of the underlying disease. It can be managed if the anemia is not severe and there are no signs of cardiovascular compromise. So, general principles of primary AIHA. So, you should treat. So, how do you first generally approach a primary AIHA? If you have any suspicion of infection, underlying cause, you treat any identified underlying cause, such as infection. Folic acid is a well-tolerated supplement to prevent a deficiency that could exacerbate the anemia. Folic acid. Then compatibility testing for patients requiring transfusion focuses on identifying the patient's ABO, capital C, small c, capital D, capital E, small e, and K status, as well as the presence of alloantibodies. This can be achieved by special techniques such as auto or alloadsorption, warm autoantibodies, or pre-warming screening cells and patient's plasma separately to 37 degrees centigrade before use in the indirect antiglobulin test. So generally what you do is to understand if it's warm or cold, we pre-warm the screening cells at 37 degrees centigrade and see their reactivity, and then differentiate into cold antibodies and warm antibodies. That happens mostly in the lab. You should just call the blood transfusion medicine personnel and ask them to look for if there are warm antibodies or cold antibodies. And then from there you can further evaluate. Genotyping can be useful, but it is not generally practiced, and it's particularly for complex cases in which it is desirable to match for an extended phenotype. So general principles are: rule out underlying cause, folic acid use supplement to mitigate the cell turnover. You should look for the compatibility testing, look for all the ABO antibodies, then look for if it is warm or cold, and then genotyping in complex cases. So even if you do a full compatibility testing, which can take 4 to 6 hours, and the units are labeled as compatible, because they should be aware that fully compatible testing, even if it takes more hours, and that the units provided should be labeled as compatible, because autoantibodies from unmodified patient plasma are likely to bind to the donor red cells in an indirect antiglobulin test cross-match. So this is also not not as it is mostly it happens in the blood bank. The lab gives us this information. So, and if there is no history of transfusion or pregnancy, the patient is unlikely to have an alloantibody. And if anemia is life-threatening, transfusion of ABO, RH, and K matched red cells may be preferable to rather than waiting for a fully compatible testing. So I'm going to tell you how, when do you jump in and give red cell transfusions, even if you know that there is autoimmune hemolytic anemia. And at that time, when you feel there is a need for giving RBCs, you don't need to wait for a full compatibility. You can just go ahead and give ABO mainly, RH, and K. You have to see compatibility for these three antibodies mainly, and then you can go ahead and give your transfusion. Venous thromboembolism prophylaxis is the risk with hemolysis is still underestimated, but remains an important cause of morbidity and mortality in AIHA. In some cities, venous thromboembolism events occurred in up to 20 to 25% of patients, usually when hemolysis was active. Larger studies have shown higher rates of venous and arterial thrombosis in patients with AIHA, and more recently in those with CAD specifically. Severe or life-threatening anemia depends on the degree and onset of anemia. So when do you say it's a severe or life-threatening anemia? If the HB is less than 5 grams per deciliter, severe and can cause cardiovascular compromise, that is called life-threatening anemia. So you give RBC transfusions So the blood bank consult, you sort the blood bank consult versus the blood compatibility, like I discussed before. Then, despite the risk of hemolysis, RBC transfusion should not be withheld from a patient with life-threatening anemia. You have to just look for ABO, RH, and K, and then go ahead and transfuse. A severe hemolytic transfusion with cold reactive autoantibodies that fix complement and can cause intravascular hemolysis. So at that particular time, what are your strategies? So you know that there are cold reactive autoantibodies that could fix the complement, and that can cause, you have this information, and how do you mitigate this particular condition? So you warm the blood to 37 degrees centigrade before and during the infusion, beginning the transfusion at a slow rate, and checking both plasma and urine samples periodically for the presence of free hemoglobin. Then you hydrate vigorously in more severe hemolysis and substantial hemoglobinuria, hemoglobinemia, and hemoglobinuria. So we have this blood warmers where you can, the blood product, the blood set is kind of goes through the warmer and then enters into the venous port. So it automatically gets warmed, and that's how you mitigate the cold reactive autoantibodies. RBC transfusion is one method, and then pharmacotherapy. In pharmacotherapy, the choice of treatment depends on the type of AIHA. In warm AIHA, the first line therapy is glucocorticoids. Its response is more rapid, short term, and greater experience with glucocorticoids in children with AIHA. So the initial dose, if HB is less than 6 to 7 gram per deciliter, IV methylprednisolone at 0.5 to 1 mg per kg per dose every 6 to 8 hours for the first 24 to 72 hours, after which they are transitioned to oral prednisolone at the dose provided below. So you start off at methylprednisolone at 0.5 if you have hemoglobin less than 6 to 7. You give methylprednisolone at 0.5 to 1 mg per kg per dose every 6 to 8 hours for the first 24 to 72 hours, after which they are transitioned to oral prednisolone. Sometimes high dose methylprednisolone pulse at 30 mg per kg with maximum 1 gram OD for 3 days may be warranted for very severely affected patients who are rapidly evolving and there is severe hemolysis. At that time, you can think of methylprednisolone at pulse doses, but generally what we start is 1 mg per kg per dose every 6 to 8 hours. If there is mild to moderate anemia, that is HB 7 to 8 gram per deciliter, an appropriate reticulocytosis can be initially treated with oral prednisolone 2 mg per kg per day in 2 to 3 divided doses. That is for mild to moderate anemia. So you have severe, mild to moderate, and you started your steroids, and then how you taper these steroids. For the first few months, when you have HB of 9 to 10 gram per deciliter, which occurs once you give steroids, with it mostly you expect the response within 2 to 4 weeks. At that time, you can slowly start tapering. First, you can taper it to a single daily dose over 2 to 3 months based on initial evaluations, HB concentration, reticulocyte count, LDH, and DAT. And then this taper prednisolone to a dose of less than or equal to 1 mg per kg per day within this time frame. So when you have to achieve this dose of less than 1 mg per kg per day. If this cannot be accomplished, second line therapy with rituximab should be started to facilitate steroid weaning. So you start your steroids 2 to 4 weeks. You look for the response HB more than 9 to 10 gram per deciliter. Then you can be tapered. Then you can taper it down to single daily dose for over 2 to 3 months based on serial evaluation of HB concentration, reticulocyte count, LDH, and DAT. Taper prednisolone to a dose less than or equal to 1 mg per kg per day within this time frame. If you can't do that, then you should think of second line rituximab. How do you subsequently taper? So once you reach a dose of less than 1 mg per kg per day, prednisolone is slowly tapered but not stopped. Immediately you don't stop it until HB normalization, reticulocyte count, LDH, haptoglobulin, all of them should be the expected what you expect. Reticulocyte count should be normal, LDH should be normal, haptoglobulin should be within its normal range. So that is when you slowly further taper, although that may remain weakly positive for a long time. So the goal when you stop it, so the goal is less than or equal to 0.2 mg per kg per day or every other day to avoid remission. So that is when you reach that dose, that time you can stop it. And patients who chronically require more than 0.2 mg per kg per day, And those who experience frequent relapses should generally be started on second-line therapy. So this is how you start, this is how you taper, and this is how when you have to think of second-line therapy. So monitoring, like I discussed, you monitor for your HP, reticulocyte count, LDH, DAT, and then in OP setting, you look for lab studies monitored once weekly as clinically better. Monitoring should continue until HP level and reticulocyte count have to be returned to normal, and patients stable on low-dose glucocorticoids. So periodically, LDH and DAT should be seen. Monitor patients for 1 year after remission has been achieved. If persistent positive DAT suggests ongoing autoimmune disease and warrants further exploration for secondary etiology such as events or SLE. So you do your DAT persistently positive, lower positive, then you look for events disease and SLE also. This is how you monitor. Response, I've already told. Expected response is stabilization of hemoglobin concentration followed by a slow increase in hemoglobin level and decreased reticulocytosis. So 24 to 48 hours is a rapid effect due to inhibition of Fc receptor, mediated clearance of sensitized erythrocytes. Poor response to initial therapy, have inadequate response to treatment during first 1 to 2 months, and or do not tolerate initial tapering of glucocorticoids, can start on second-line steroid-sparing treatment. Relapses, common in AIHA in initial 6 months to 1 year after initial response. So when you have a relapse, you can restart low-dose prednisolone that was previously effective in maintaining the patient in remission. So when you're tapering, you will know which dose the patient has stabilized, so that you can retrospectively go back and start off at that dose, or you can start at a lower dose of prednisolone first, and then slowly build up. And second-line therapy, patients with frequent relapses and those in whom remission cannot be maintained off prednisolone or low-dose prednisolone, less than 0.2 mg per kg per day, should be treated with second-line therapy. These are the indications when you have to start second-line therapy. Frequent relapses and those who cannot maintain off prednisolone at 0.2 mg. And then second-line therapies are rituximab, like we all know, 375 mg per meter square. That is with steroids or without steroids. You can introduce it while weaning the steroids. So its dose is once in a week for 4 weeks, and response you achieve at 2 to 4 weeks. If relapsed, then second course of rituximab also can be given and you can achieve remission. So you should look for a lymphocyte subpopulation every few months and can help in assess treatment response. Rituximab has a thing of causing hypogammaglobulinemia, so you should keep checking your immunoglobulins, and if required, you have to give IVIG. And there are other adverse effects, including infusion reaction, opportunistic infections, and/or viral reactivation, which cause progressive multifocal leukoencephalopathy. Splenectomy is another second-line management. So the first line is steroids, second line is rituximab and splenectomy. Splenectomy is effective for children with chronic or recalcitrant primary AIHA that approximately 2/3 shows short-term improvement, usually 2 weeks following surgery, because of post-splenectomy sepsis caused by encapsulated bacterial organisms. Splenectomy should be avoided in children less than 3 years of old and should be postponed to more than 6 years of old. You should be ideally immunizing them against the encapsulated organism. Children who underwent splenectomy should receive antibiotic prophylaxis, should be instructed to seek immediate medical attention. So we've done with first line, second line, now the third line. Third line is IVIG, danazol, which is not yet studied in children very, very much. So a lot of studies are happening. Then azathioprine and 6-MP, it has both of them have an effect on T lymphocyte helper function. So that's how they diminish the autoantibody synthesis and exert steroid sparing effect. So you need a 2 to 3 months of therapy with both of them. Cyclosporin, we use cyclosporin in a number of things in GvHD prophylaxis and immunosuppressive therapy. So this is also one more place where 1 to 3 mg per kg per day divided in 2 doses 12 hours apart. MMF, tacrolimus, sirolimus, cytotoxic agents, monoclonal antibodies like obinutuzumab, anti-52 monoclonal antibody, and Campath. All of them are third-line therapies. But they're not fully used at this point. They're all in trials. Then you have bortezomib, which is a refractory AIHA. It's a proteasome inhibitor, depletes plasma cells and affects antigen presentation. Then you have spleen tyrosine kinase inhibitors, that's called fostamatinib. therapeutic plasma exchange, HSCT, very rare, and complement inhibitors. So all of them, third line therapies are most, except IVIG, MMF, tacrolimus, cyclosporin, azathioprine 6-MP. All the other ones are quite under trials, and they need to be studied extensively to really get them into the mainline treatment. Coming to secondary AIHA, I've discussed all of this is primary AIHA. How do we approach? What is the treatment? What are the steps you need to do to get to the cause of primary AIHA, or how to manage primary AIHA, and then how do you treat first line, second line, third line. Now secondary AIHA. Secondary AIHA, treat the underlying condition according to the best practice. Successful treatment may also improve the AIHA, but that is not always the case because the strength of the association varies. And if the associated condition does not require treatment, AIHA can usually be approached in a similar fashion to primary AIHA, although treatment decisions must be individualized. EVAN syndrome, glucocorticoids and IVIG, rituximab, MMF, and sirolimus. Splenectomy, patients who fail medical therapy. Immunodeficiency, AIHA may occur in patients with CVID, Wiskott-Aldrich syndrome, CTLA4, haploidentical with autoimmune infiltration, LRBA deficiency, STAT3 gain of function, mutations, and HIV. So all of these are secondary causes. In autoimmune lymphoproliferative syndrome, steroids are the mainstay. In SLE, methylprednisolone, Pulset for 3 days, and drug-induced AIHA. All of them are secondary causes. Next, we have cold agglutinin disease. When you do a DAT, when you found it positive, and then when you elucidate if it is warm or cold, and then in cold, you look at the titers. If it is more than 1:64, then it is a cold agglutinin disease. So in cold agglutinin disease, the most common thing is intravascular hemolysis that can be triggered by bacterial or other febrile illnesses and should be treated promptly. Patients with cold agglutinin disease should avoid exposure to cold weather where possible and rest to protect the distal extremities. While in hospital, the patient should be kept warm, especially in the perioperative period. When you're doing a cardiopulmonary bypass, it presents as a particular challenge related to the usual practice of systemic cooling and cold cardioplegia. So, however, systemic normothermia and warm cardioplegia is a recognized method, and we can adjunctively give eculizumab. It can be successfully used to cover bypass surgery. Then patients should not receive cold fluids, IV, and so this is what I was talking about. Use of an inline blood warmer is recommended. So inline blood warmers are present in many centers where when you have cold agglutinins or cold antibodies, you can pass through this inline blood warmer directly while transfusing, and then you can safely transfuse. So this is the last slide. So when you're receiving steroids, there are particular first line is steroids in AIHA, and sometimes I've told you we expect response for 2 to 4 weeks, but we should give it for 2 to 3 months, and then our aim to stop steroids is less than 0.2 mg per kg per day. So sometimes that takes time. So when these side effects we look for in children, but we find them in adults more so because adults have a lot of other comorbidities associated. Because of an increased risk of on steroids, there could be GI complications. So antacid therapies, PPIs, is recommended. And if there is an additional risk factor such as previous peptic ulcer disease, or in children we can think of any intestinal diseases like Crohn's, ulcerative colitis, or even in children peptic ulcers, or any long-standing gastritis. Any concomitant non-steroidal anti-inflammatory drug, anticoagulants, aspirin use, or concomitant thrombocytopenia. All of these are particular risk factors for GI complications while receiving steroids. So the fracture risk is increased in patients receiving glucocorticoids for more than 3 months. So at a prednisolone dose of more than 7.5 mg per day. It is recommended that these patients are advised about lifestyle modification. So smoking and alcohol is for adults, but engaging in regular weight-bearing exercise is also for adults. But you can give a daily vitamin D maintenance dose, and also look at vitamin D deficiency and supplement vitamin D if needed for children. Fracture risk is more high in adults for more than 40 years of age. So at that time, we should think of oral bisphosphonates should also be prescribed, like zoledronic acid and all of that. And yeah, this is for postmenopausal and older 50 years age. That's not quite helpful in children. So yeah, this is how you manage autoimmune hemolytic anemia. How to diagnose primary, secondary, then warm, cold, PCH, um, severe, mild, moderate anemias, and when do you give RBC transfusions? When do you start your therapies? And yeah, thank you.